Hello, everyone, and thank you for attending my talk titled Exploring the Diagnostic Journey and Life Impact of Cholangiocarcinoma Results from a Large Patient Survey in the United States. I'd like to give a warm thank you to the Cholangiocarcinoma Foundation for allowing me the opportunity to express some of the findings that came from this survey that we conducted among cholangiocarcinoma patients. The research objectives of this survey included the following. First, we wanted to characterize aspects of the cholangiocarcinoma patient's disease and diagnosis experience. Next, we wanted to understand the patient's experience with respect to current and past treatments, as well as understanding their own perspectives on prior therapies and the outcomes of those therapies. And finally, and probably most importantly, we really wanted to explore the quality of life and psychosocial impacts of disease management and the patient journey. This is a brief snapshot of the methodology that we employed on the survey. We recruited 707 patients in partnership with the Cholangiocarcinoma Foundation, and the way that they're presented are stratified by the stage of disease of the participating patients. You'll note here that we had 157 patients in stage 1 and 2, and then we recategorized stage 3 into stage 3A and stage 3B. And we'll talk a little bit about that on the next slide on how we characterize that. But the bulk of patients were in the stage 3 category. Finally, we asked patients if they had been diagnosed with stage 4 cancer indicated by the spread to another organ. And then we also offered the opportunity for patients to express that they currently had no evidence of disease or were in remission. The survey itself was 30 minutes and was conducted online last summer between August and September. And throughout the survey, you'll note that we did employ some statistical testing where it was appropriate. This is an example of the question that we used to categorize the patient's understanding of their stage. We thought that it may be helpful to provide some word anchors to each stage to help them understand and put themselves into the appropriate categories. So stage 1 and 2 was defined as early stage. Stage 3A was categorized as being a potential candidate for surgery. Stage 3 had progressed to the point that surgery was probably not an option. Stage 4 was indicated by my cancer has spread to another organ. And then finally, we had 2 categories for no evidence of disease. And we also offered the patients the opportunity to say that they didn't know which stage they were in. This is a brief snapshot of some of the baseline characteristics and the demographics that we had of the patients as stratified by the stages that they were in. So you'll note the total patients is indicated on the leftmost column and then stratified by the various stages to the right of that. What's most noteworthy is that most patients were over the age of 45. We had predominantly a male sample, and most of the participants or the patients had completed at least some college or greater. An overwhelming majority of patients were married or living with a partner. There was a pretty even stratification of the various income levels that we asked, and a majority of patients were also receiving medical insurance either through Medicare or Medicaid. So to talk a little bit about the diagnosis journey of the cholangiocarcinoma patients, we asked when their first symptoms were noticed, and then we asked when they received their cholangiocarcinoma diagnosis. And we note that on average across this entire sample, about 22 months transpired between the first notice of the cholangiocarcinoma symptoms up until the diagnosis. The average age at diagnosis was 44 years old, which we note is a little bit younger than we would have expected, but may be indicative of the sample that we selected within the Cholangiocarcinoma Foundation. Once we understood that the average age at diagnosis was 44, the average current age of the sample was 46, indicating that approximately 2 years had passed from the time that they received their official diagnosis to the time of the survey. On the lower left-hand corner, you can see the distribution of the disease stage at diagnosis and current. Perhaps not unsurprisingly, we see that a number of the patients have moved from one stage into a later stage between their diagnosis and where they are currently. The type of CCA was also probed from each of the patients, and you'll note that a large proportion was representing the perihilar cholangiocarcinoma or Klatskin tumors, followed closely by the intrahepatic cholangiocarcinoma patients. We had a very small proportion of patients with extrahepatic disease or distal CCA. One of the interesting findings that came out of this survey was how frequently patients were misdiagnosed. And so we bring forth here a pie chart that asked patients whether or not before their official CCA diagnosis, if they had been diagnosed with another cancer. Just about 1/3 of patients indicated positively that they had received a diagnosis of another cancer, in which case they were skipped on to the next question, which asked which cancer it was. And you'll see that more than half of the patients who have cholangiocarcinoma were initially diagnosed with gallbladder cancer. In the lower left-hand corner, you'll note that just over half of patients also sought a second opinion or a third opinion of an oncologist at the time of diagnosis, and that the total number of oncologists that were consulted throughout the diagnosis journey was approximately 2.5. And again, perhaps unsurprisingly, walking through this bar chart, the specialist physician making the diagnosis was most frequently an oncologist, although you see that it also appeared in primary care physicians, gastroenterologists, emergency medicines, hospitalists. We asked the patients what really drove or motivated some of the decisions that they had in selecting their upcoming treatment. And physicians' judgment rates as the number one motivating factor for why they chose the treatment that they did. But what we found interesting is out of this long list of other potentially motivating factors, and the patients were allowed to select all that apply, was the fact that the quality of life that would be expected on that treatment rose up to be just underneath the physician's judgment themselves. We also asked what the primary consideration was. So on the left-hand side, they can indicate, check all that apply. These are all of the factors that would be important in making my next treatment decision, and then what the primary consideration would be. And again, the physician's judgment appears at number one in both spots. We did find when we looked at it by stage, though, that the later the stage the patient was in, the quality of life began to creep up and up to even rival the importance factor that was given to it to be consistent with the physician's judgment. This next list was developed with a key external expert panel in conjunction with the Cholangiocarcinoma Foundation to derive some cholangiocarcinoma specific symptoms. So on the right-hand side, you'll see the list of the 16 symptoms that were identified and asked of patients whether or not they had experienced any of them. On the left-hand panel, you'll note that 100% of all of the patients that we asked experienced at least one of those symptoms. And the average number of symptoms reported having an impact on their day-to-day life out of this 16-item list was 14. This is a breakdown of those 16 CCA-specific symptoms, and it notes the proportion of patients who responded that that symptom had a great deal of impact or a considerable amount of impact on their day-to-day life. And these bars may not look that different to you, and that's because they're not. But what we found was important is that there was so much gravitas that was given to each of those symptoms that we thought it was important to share with you that there's not any one symptom that is affecting these patients' lives. It's all of them. So probing further on the impact of day-to-day life, we also employed some validated tools to assess different aspects of the quality of life. So first beginning with their work productivity, among the patients that were still currently employed, we looked at the impact that CCA and the treatment had on the work productivity and their activity. And so you'll note that there was a very high degree of impairment while working among the overall work impairment among those who are currently employed, and also a very high degree of activity impairment among the total respondents. We also have the pie chart in the middle that talks about the impact that CCA had on the work status. So you'll notice that there is a huge proportion of patients who are reporting at least some degree of impact. Very, very few of the patients reported CCA having no impact on their life or their work status. In the upper right-hand corner, and we'll probe into this more on future slides, is a pictograph of the distribution of depression scores as indicated using the PHQ-9 scale. Now, the PHQ-9 scale is a screening tool with 9 items that is intended to pick out patients who may be at risk or deserve further evaluation for major depressive disorder. So you'll note that nearly half of the patients that we surveyed, 47%, screened high enough on that PHQ-9 scale to indicate that they may have severe depression. And we think that that's an important finding that hasn't been appropriately studied in the literature. And then finally, what was interesting to us through discussions with the Cholangiocarcinoma Foundation was the impact that cholangiocarcinoma may have on the sexual relationships and function of the patients themselves. So what we did here was we did not use a validated scale, but rather probed on 2 items of interest that had been explained to us from the cholangiocarcinoma based on patients who had been discussing among discussion boards where they may be experiencing trouble. So those 2 things were having a lack of sexual desire and a loss of intimacy with the partner. So we asked 2 questions, whether or not they had experienced either of those things, and then to what amount the impact was on their life based on the existence of those items. This is just a line graph that details, again, the number of symptoms that we talked about out of that 16-item list. It's stratified by stage. And what we found was interesting here is that stage 3A, as shown as the second dot from the left among the different lines, there is a blip showing that the stage 3A patients have greater impact to their lives. And we don't yet really understand that, but it may be indicative of their place in life, that they're still trying to work. Perhaps they are within the demographic that's taking care of parents or children, and their life responsibilities just exceed those, as well as the stress level of trying to manage disease that is perhaps indicative of some spread. Thought that was interesting to point out as well. Okay, we'll talk about this EORTC QLQ Bill 21, which is an alphabet soup, but it represents a validated tool that is exclusive to biliary tract cancers. So it's a 21-item questionnaire that is targeting symptoms that are specific to biliary tract cancers. It is validated. It's used very widely in clinical trials and in other academic research, and it's provided a wealth of information, but it is important to keep in mind that it's not necessarily specific to cholangiocarcinoma, and it may include other liver-involved diseases, symptoms that are consistent with other liver-involved diseases. So the scale itself includes many subscales, and those subscales are listed below and include eating problems, jaundice, tiredness or fatigue, pain, anxiety, treatment side effects, issues with drainage bags or tubes, and weight loss. This is a breakdown of the scores for each of those different domains that are part of the Bill 21. And you'll note here that this is also, like we found previously, pretty consistent impact among all patients for all of the scales. So there's not one domain that tends to explain why there is such a big hit to quality of life in these patients. They're all important. Interestingly enough, we decided to look at the different domains and stratify it by age. And with exception to weight loss that was experienced with the highest degree of report for weight loss in the 45 to 50-year-old age group, the younger group, so the group that was 18 to 44 years old, had the biggest impact on their quality of life score. So they had the worst experience with all of those different domains aside from weight loss. And we thought that that was an interesting finding, that these younger patients are registering with worse quality of life scores. So again, this is probing that PHQ-9 score just a little bit further and breaking down the score by the stage of cholangiocarcinoma. Perhaps what's most importantly, again, is to zero in on that stage 3A patient population, where over half of those patients are qualifying as severely depressed and deserving of further evaluation for major depressive disorder. So in the PHQ-9, if they do respond that they have at least some impact for each of these items within the tool then directs them to say, out of all of the items that you may have responded having an impact, can you elaborate on the difficulty that you have in your day-to-day life that are caused by these problems? And that's indicated by this pie chart on the right, where you'll note that many of them are having a very difficult or extremely difficult time and a great deal of difficulty by the problems that are experienced in the PHQ-9. So these are aside from their CCA symptoms. These are the depressive markers that are driving the difficulty in their life as it's experienced through this survey. So this is probing a little bit further on those sexual function questions that I elaborated on earlier. So on the left-hand side, you see the question that we asked on lack of sexual desire. And on the right-hand side is the loss of intimacy. So on the left-hand side, when we have the lack of sexual desire, those are the patients that responded that they did have some impact. So some impact is in gray, considerable is in orange, and a great deal of impact is in blue. When they responded that they had at least some impact, we then asked if we thought it was due to the symptoms or the treatment itself. What we did not find is any big difference between the cholangiocarcinoma symptoms themselves and the treatment that's associated with the CCA. So that probably just indicates the fact that the patients are unable to tease out whether or not that any evidence of lacking sexual desire is coming from the treatment or the disease itself, which perhaps may be not surprising. On the right-hand side, we have a loss of intimacy. And you'll notice that unlike the lack of sexual desire, it appears that the loss of intimacy, while it's still important and still impactful, it's creating less of an impact, less of a big deal in those patients' lives than did the lack of sexual desire. So we thought that that was important to share with you all as well. So in conclusion, there's been a lot of information that we've been able to get out of this survey. It's been so tremendously helpful to us establishing further knowledge on the natural history of the disease and how the patients go through their diagnostic journey and how do they feel and what is their quality of life while they are undergoing treatment. So the conclusions that we have on this is that being diagnosed with cholangiocarcinoma is a long process that happens over a number of years. And for the patients that we surveyed, it's happening to them in the prime of their lives. And it's taking on average 2 years to get to an appropriate diagnosis. And then once they get there, we know that a third of those patients are initially misdiagnosed with a different kind of cancer before they even arrive at the cholangiocarcinoma diagnosis. We also know that the journey to diagnosis is more arduous for patients diagnosed with intrahepatic CCA, which may be indicative of the fact that they do not experience some of the outwardly seen symptoms that you may see with some of the extrahepatic patients. So it takes a little longer to get to the right diagnosis in those patients. We also found that the disease burden impacting the patient's daily lives and their mental health is immense. So we know that they experience an unbelievable number of symptoms that are impacting their day-to-day lives. And we know that a lot of these patients, nearly half of them, are screening as severely depressed. So that definitely warrants further research, better understanding, better outreach in terms of how these patients' mental health can be managed. And we also know we're going to plan on doing some additional work to tease out what makes these stage 3A, as we define them, these stage 3A patients, different from some of the later stage patients. And we didn't see a clear trend that we would have expected, but instead saw that blip that came up in the stage 3A patients and then sort of fell back down to be consistent with the earlier stage as they got to the stage 4. That was a surprising finding that we plan on doing more research on. And that's it.
Greetings. It's a pleasure to discuss the bile duct cancer genome-wide association study as part of the Cholangiocarcinoma Foundation 2020 annual meeting. So I'll be describing our efforts to identify novel genetic loci for development of bile duct cancer. And I wanted initially to acknowledge my collaborators, Drs. McGlynn, Chris Amos, and Dr. Manal Hassan, particularly, as well as numerous additional colleagues who have assisted with the analyses to this point. So here on this slide are the major collaborators from multiple institutions who have contributed samples to this analysis. And here are a few disclosures. So in terms of background, I think you are all familiar with the term biliary tract cancer, which includes cholangiocarcinoma as well as gallbladder cancer. These tumors have relatively similar incidences in terms of cholangiocarcinoma and gallbladder cancer, but also have the common characteristic of being highly lethal. They tend to be diagnosed at late stages and have very short survival. Although some of the risk factors for biliary tract cancers, specifically cholangiocarcinoma, are known, the proportion of the risk for cholangiocarcinoma that is attributed to inherited predisposition has yet to be determined. Recent genome-wide association studies have identified multiple genetic variations that are associated with risk of developing different cancer types, including colorectal cancer, breast, lung, pancreas, melanoma, and brain cancers. This has stimulated our interest in developing a genome-wide association study for biliary tract cancers and specifically for cholangiocarcinomas. And so what we have assembled here is the first large cohort genome-wide association study in biliary tract cancer that is sufficiently powered to detect statistically meaningful associations between gene variants and biliary tract cancer in patients of European descent. So our study rationale or hypothesis is that there are unique host genetic factors or gene variants that can predict risk of cholangiocarcinoma in non-PSC cases. You're all aware that PSC, or primary sclerosing cholangitis, is a well-known risk factor for cholangiocarcinoma. And what we are testing is that we might find factors that can predict cholangiocarcinoma risk in non-PSC cases, as well as potentially different markers that might predict cholangiocarcinoma development in patients with PSC. A sub-hypothesis is that some of these variants might be possible to identify that could predict clinical outcomes in cholangiocarcinoma. So we expect that our findings will open up new avenues of research into the molecular pathways involved in both non-PSC and PSC-related cholangiocarcinoma. And these findings might influence stratification of patients, staging, and prognostication in cholangiocarcinoma, and further allow us to understand the biology of the disease, allowing development of novel targeted therapies as well as preventive interventions for this disease. So our aims specifically are a discovery phase, which proposed to genotype approximately 660,000 signal nucleotide polymorphisms. These are regions of the genome that are highly polymorphic and tend to be variable across individuals, using this Illumina Infinium Global Screening Array. And our hope was to genotype approximately 2,600 cholangiocarcinoma and 600 gallbladder cancer patients in the initial discovery phase and compare them to matching controls with 3 controls to each case. Subsequently, we hope to do a validation phase, which would be an independent sample of up to 5,000 cholangiocarcinoma cases and approximately 6,000 controls from another 30 collaborating institutions that we hope to genotype using the same array, and also using a more targeted array to more carefully examine the regions that were identified in the discovery phase. And then finally, we have an aim in specific aim 3 of identifying rare coding variants that confer risk of cholangiocarcinoma using whole genome sequencing of 1,800 cholangiocarcinoma cases and matching controls. This just shows you the list of the institutions from which we were able to recruit samples from patients for the discovery phase. And you can see quite a range of institutions. And these, we also show you the numbers of cholangiocarcinoma and gallbladder cancer cases that we assembled from each institution, have a wide range of numbers of cases from different institutions, depending on the frequency with which they see cholangiocarcinomas. This next table shows you the distribution by country. So you can see that of the 2610 cholangiocarcinoma cases that we were able to recruit, approximately 1,500 were from the United States, about 300 from Canada, 260 from Denmark, 180 from the UK, 150 from Germany, 86 from Sweden, 89 from Spain, 19 from Australia, and 21 from Norway. And we have, fewer for gallbladder cancer, but a total number of samples accrued of 3,278. So in terms of the discovery phase results now, what I'm showing here is a breakdown by race as well as by gender. And you can see focus, because of the numbers of samples available, will be on the European cohort. And you can see we had 1,281 European males and 1,131 European females with cholangiocarcinoma in the data set, making a total of 2,412 individuals with cholangiocarcinoma. And then I show you the Asian numbers as well. And then further down, I break out the cholangiocarcinomas by intrahepatic and extrahepatic, as well as PSC associated. So that gives you some idea of the numbers of the different subgroups that we had. So this is the first initial pass in analyzing the data set. And we started out with the European samples with 2,412 cases matched 3-to-1 with a group of controls that were from the PLCO consortium, which had genotyped several tens of thousands of individuals that could serve as controls for our study. On the right side, you will see what we describe as the Manhattan plot. And so the Manhattan plot shows you the different chromosomes. And so we go from chromosomes 1 to 21, and we've color-coded them alternately so you can distinguish between the different single nucleotide polymorphisms or SNPs on individual chromosomes. So the chromosome 1, for example, is in blue and chromosome 2 in green, and alternating down the chromosomes. And then on the y-axis, what we have is the negative log to the base 10 of the p-value. So this is the level of significance that shows the difference between one SNP, the frequency of a SNP in the cases versus the frequency in the controls. So where there's a significant difference in the cholangiocarcinoma cases versus the controls, we see a very small p-value, which is indicated in this negative log scale by a high number. And the typical cutoffs for significance in the GWAS is 5 times 10 to the minus 8, and that's the red line that you see going across horizontally. So what you see here is that in chromosome 2, there's one single spot that goes above the significance line. In chromosome 4, there's a single spot, but in chromosome 6, we see several spots that form a peak that go above that line. And in chromosome 11, we also see a single spot that goes above the peak. And the next plot to the side of this in the box shows what we call a quantile plot of observed p-values versus expected p-values. And what this really shows is that where you deviate from observed being equal to expected, you see this departure from the red line. But we'll focus for our purposes primarily on the what we call the Manhattan plots, which have the green and blue colors. So so this shows you here then all European samples. Looking more closely at the analysis, we found that this signal that we saw in chromosome 6 appeared to be significant also when we looked at males with extrahepatic cholangiocarcinoma. And then in the next slide, also particularly when we looked at individuals with primary sclerosing cholangitis. So this seems to be a signal that is fairly highly associated with primary sclerosing cholangitis. It seems more important in males. And that's, of course, interesting because we know that primary sclerosing cholangitis is a disease that occurs much more commonly in male individuals. So looking more closely at the analysis, though, one of the things we observed was that it appeared that the signals we were seeing in these European males in the chromosome 6 region appear to be dependent on selection of controls. So if we selected a different set of controls, we got a different signal. And this led us then to use what is called principal component analysis to try to select a group of controls that most closely matched to the cases in terms of their background. And what we observed then is that if we most closely matched the individuals by their genetic backgrounds, the signal that we saw disappeared. Now, this suggests that the signal we are seeing is associated with genetic background. Now, we do know that PSC as a disease is associated with Northern European ancestry. And so what we suspect is that this signal is telling us that at least for some of our cholangiocarcinoma patients, they're carrying a signal that's associated with Northern European ancestry, likely related to their having primary sclerosing cholangitis. Now, what I'll do is skip here. You can see this slide shows us European intrahepatic samples, and you can see there are a number of signals that reach a lower threshold of 10 to the -5, but do not reach the higher threshold for SNP analysis. The challenge here is that there may be signals here that are real, but we may not have enough samples in this cohort for these to rise to the level of significance. And similarly, we see a few here if we look at intrahepatic males that are above the level of nominal significance at 10 to the -5. And some here also, if we look at extrahepatic signals, you can see there's maybe one and in chromosome 22 that reaches the level of significance. So I'll move on to our next steps, because our next step that we would like to proceed with is to take an independent sample of at least 3,000 more cholangiocarcinoma cases, hopefully up to 6,000, and replicate this analysis with the goal of having enough variants that are significant, and because we have a larger group of cholangiocarcinoma cases. And then, as I mentioned, we'll also like to do whole genome sequencing. And what this allows us to do is to identify important variants that would be too rare to be reliably seen on a genome-wide association study chip, but that might be identified by whole genome sequencing. We expect that these findings will open new avenues of research into molecular pathways involved in cholangiocarcinoma development. These are the about 30 sites that have agreed to participate in the replication phase. And this is just the overall structure of how we plan to proceed with the next steps. A few references, and I'd like to acknowledge our funders, particularly the Cholangiocarcinoma Foundation, the International Hepatobiliary Neoplasia Biorepository, and the PSC partners who have been funding us for the last 2 years. And thanks very much for your attention, and I'd be happy to answer any questions.
Hello, everybody. I'm Eileen O'Reilly, a GI medical oncologist at Memorial Sloan Kettering Cancer Center. And thank you very much for having me today. The topic for discussion is BRCA and DNA repair alterations in biliary cancers. So just acknowledging disclosures and recognizing that there'll be a number of off-label and investigational drug uses mentioned during the talk. So this is the agenda to discuss the state of the understanding regarding somatic and germline testing in biliary cancers, and then to address novel therapeutics with regard to DNA repair strategies, a focus on platinum, PARP inhibitors, and a mention of immune oncology agents and how they interface in this area. So just a reminder of how we do genetic testing in biliary cancers, and this refers to both somatic and germline testing. We use a video educational tool that the primary treating physician will review with the patient, and following discussion and answering questions, if a patient elects to consent, we'll go ahead and process that, and the results are then communicated back to the individual by the treating physician. And if there's a pathogenic germline alteration, then our genetics colleagues will engage and follow on for discussion. And this really makes the process efficient and manageable and allows this information to be available readily early in the treatment disease course. And just looking at this whole process, so consent provided, typically we'll use blood as the normal DNA, although occasionally saliva or normal related to non-tumor tissue if that only was available. Samples are processed, next generation sequencing is undertaken, variant calling is done using a variety of reference databases, including OncoKB, and then these data are included in the medical record and in CABI portal, which can be accessed in a de-identified fashion external to the institution. And all of this, when tissue is in hand, takes about 3 weeks or so. So moving then to the data regarding germline results in biliary cancers. This is a recent publication by our group. 131 patients were evaluated, and of that group, about 2/3 had an intrahepatic cholangiocarcinoma. And for those who had a pathogenic germline alteration, the median age was 53, which was younger than the overall group by about 6 years. And 16% or 21 of these patients had an alteration in a high or a moderate penetrance predisposition gene. We didn't actually see any difference between the different types of biliary cancers, recognizing it's a relatively small data set. And looking at this in a little bit more detail, here's the spectrum of alterations driven by BRCA2 in particular. There were 7, that's about 5% of the cohort when you combine BRCA1 and BRCA2. Come back to BAP1 in a minute, and then a smattering of other lower frequency alterations, including ATM and MBN, PALB2, and a patient with Lynch syndrome included in this data set. So looking at BAP1, this is important in biliary cancers. It stands for the BRCA-associated protein 1, which is a tumor suppressor gene and has a variety of physiologic functions. It's part of the deubiquinase series of enzymes. And here is outlined some of the physiologic process that BAP1 is involved in and how it may be associated with implications in terms of malignancy. There's a predisposition syndrome which involves melanoma, both uveal and cutaneous, mesothelioma, renal cell carcinoma, and biliary cancers being the point of relevance here today. So looking at a couple of other data sets, this is a group from Beijing who looked at a cohort of 350 patients with liver cancer. So it included some patients with HCC as well as biliary cancers. And they used a next generation sequencing with a 450 gene panel. And here the goal was to look at DNA damage repair alterations. And you'll see that about a quarter of patients had an alteration in the DNA damage repair gene, and about 15 patients had positive germline finding. So about a quarter of the population had a finding that was potentially actionable from the DNA repair strategy perspective. And they provided some data on a retrospective cohort of 8 patients, all of whom had intrahepatic cholangiocarcinoma and were treated with a PARP inhibitor, olaparib, and 3 had partial responses, all in BRCA mutations, which were truncating and presumably pathogenic. So this is the spectrum of these, the landscape of DDR gene mutation alterations, and you'll see the functional class that was impacted here. And again, just going back, about a quarter of patients in the tumor had an alteration, and about 6% in the germline using the panel that this group utilized. So moving on, this is another cohort of patients with biliary cancers. And here a different next generation sequencing panel was utilized, including 20 DNA repair genes, and the investigators classified as direct or caretaker, i.e. associated genes. And if we look across the spectrum of biliary cancers, about a quarter of patients with extrahepatic cholangiocarcinoma in this cohort had a direct gene alteration, and somewhat less so in intrahepatic and gallbladder cancers. And just keeping in mind that this was also potentially correlated with an elevated tumor mutation burden, and again, suggesting some implications with regard to treatment. So now moving to the topic of targeting genetic alterations in biliary cancers with a focus on DDR. And there's not a huge amount of data as yet, but this is clearly an area of great interest, and we're starting to see some active trials in this space. So looking at a healthy cell, the two processes of DNA damage repair alterations are repaired by homologous repair and base excision repair. In a cell with a BRCA mutation, the homologous repair process is impacted, and in a normal cell treated with a PARP inhibitor, base excision repair and PARP inhibition is out. And when you put both together in a cell with a BRCA mutation and a PARP inhibitor, you induce synthetic lethality because both mechanisms of DNA repair are impacted, and that leads to apoptosis and cell death. So looking at this cohort from Korea, it included 137 patients with biliary cancers, and 16 of that 137, or 18%, had a mutation in a DDR gene. A majority of patients received platinum therapy, as you might expect, as that's standard for this patient population. And when the investigators looked retrospectively for those who had a DDR mutation compared to those who did not, the response was not quite, but almost double. There was an impact on progression-free survival and also an impact on overall survival, and that was statistically significant. And it's also important here to acknowledge that there were probably some biases in terms of who received platinum and who didn't as an initial treatment strategy that may be implicated in terms of the survival difference. So this is the oncoprint looking at the landscape of biliary tract malignancies and a variety of gene alterations. The genes being listed vertically, and the malignancy type, the specimen, survival, being illustrated along the top axis, and just gives an overall snapshot of the frequency of these alterations in biliary cancers. And here's the data as we've shown, again suggesting that if you have a DDR mutation and you receive a platinum therapy, that your outcome is likely better. And these data are very concordant with several data sets now that are available in pancreas cancer, again suggesting the same theme, that it's important that a platinum agent be delivered as an initial treatment approach to maximize outcomes. So what about PARP inhibitors in biliary cancers? Dr. Galan and colleagues provided one data set. This was a retrospective cohort study looking at 18 patients who had biliary cancers and were treated with a PARP inhibitor. And you'll see 5 patients had a germline BRCA1 and BRCA2 alteration. An additional 13 had a somatic alteration, and a good percentage were treated with platinum-based therapy. Of the 4 who received a PARP inhibitor, 1 had a sustained and durable response. And the survival signal was overall encouraging, and again recognizing the biases that go into retrospective cohort studies, but survival of almost 2 years in advanced disease suggests that there may be a real signal here. So there are a couple of studies ongoing. One is a phase 2 trial of single-agent olaparib, led by Daniel Ann and Milan Javli from CRU. And this is looking at single-agent olaparib in the context of platinum-sensitive biliary cancer with a primary endpoint of response. And you'll see these are the genes that are included with regard to eligibility. We'll have some data emerging from a trial that's still underway in the context of BAP1 positive malignancies, but there was a second cohort for patients with DDR gene mutations looking at single agent niraparib. So we'll look forward to seeing how that plays out. So just a brief couple of remarks on the strategy of platinum and immune therapy in the setting of DDR mutations. I think this is a very interesting concept that needs to be further developed in biliary cancers. And these are two recent data sets that were presented at ASCO 2020. The first was a randomized phase 2 conducted in the US, looking at gemcitabine cisplatin with nivolumab, or nivolumab and ipilimumab as an alternative frontline strategy. And the data here are not mature, but the progression-free survival looks interesting for the combination of gemcis and single-agent checkpoint inhibition. Recognizing this is not a selected population, but I think a retrospective analysis may provide some insights into the subgroup with DDR mutations to see if there's a signal there and if that might be worthy of pursuit in that patient population. And similarly, additional data from our colleagues, primarily in Asia, looking at the combination of chemotherapy and 1 versus 2 checkpoint inhibitors. And you'll see there appears to be an interesting signal in terms of PFS approaching a year and survival 18 to 20 months. So again, these data sets are not mature, but clearly an area of significant interest. And an ongoing study is looking at pembrolizumab in addition to chemotherapy, placebo-controlled for the checkpoint inhibitor. And this is a large multinational trial in untreated locally advanced and biliary cancers. And again, hopefully we'll have some insights when this is completed regarding the signal in this patient population. So I'll leave you with these conclusions. So the best evidence suggests that DNA damage repair alterations are present in somatic and germline in about 20 to 25% of patients with biliary tract cancers. That there may be a survival advantage when platinum is used. Again, it's hard to tease that out because platinum is standard regardless. Certainly suggesting that PARP inhibitors have a value in this patient population, and several prospective studies will address this more definitively. There are a number of themes that emanate from other malignancies that are beginning to be explored in biliary cancers, and one is the concept of patients with IDH mutations and PARP inhibitors based on preclinical data suggesting a synergy. And there's trials about to be activated in this space. We've mentioned the context of DDR and immune therapy, and also targeting BAP1 with PARP inhibitors and potentially EZH2 inhibitors such as tazemetostat, for which there's a precedent in mesothelioma, is an attractive consideration for development in this space in biliary tract cancers. So thank you very much. Enjoy the rest of the meeting.
Good morning. I'm Chiara Braconi from the University of Glasgow, and I would like to thank the organizer for the invitation to give a talk about diseases at risk for cholangiocarcinoma development, primary sclerosis, cholangitis, and Lynch syndrome. So before we dive into the details of these diseases, I'd like to remind that most cases of cholangiocarcinoma are sporadic, where we cannot identify any risk factors or risk conditions. So to the question, why is my tumor developed? Most of the time, we do not have an answer. However, there are a few examples where there is a strong association between a disease or a condition and the development of cholangiocarcinoma. And this seems to be different according to the geographical distribution of cholangiocarcinoma, with a prevalence of liver fluke for the East world. And then for the west part of the world, we have a primary sclerosis cholangitis, which is associated to cholangiocarcinoma. I would also like to add the Lynch syndrome, as this is a disease with a germline, a genetic modification that we know can determine development of cancer. So if we take this aside at the moment, we also need to think that there are a number of other risk factors that are associated and are currently studied as risk factors for cholangiocarcinoma. There are different reports in the literature. This is just one of the most up-to-date meta-analyses where the authors have nicely identified the different risk factors for intrahepatic or extrahepatic cholangiocarcinoma. Again, if you take aside the choledochal cyst, which is a very rare genetic disease, then you can observe that for intrahepatic cholangiocarcinoma, we mainly have cirrhosis and the diseases that lead to cirrhosis, while for extrahepatic cholangiocarcinoma, we mainly have lithiasis and inflammation of the bile duct system. So now, moving back to the main topic of the presentation, I will start with the primary sclerosis cholangitis, or PSC. Now, you might be aware this is a very rare disease which starts in young males, usually starts at the age of 20, 30, with a peak at the age of 40, and is characterized by a derangement of the anatomy of the bile duct system with multiple strictures. The reason why this PSC arises is still unclear. It looks like there is a contribution of several factors, and these include the diet and the microbiota, the toxic effect of the biles, as well as some genomic predisposition, which is not a genetic disease, which is inherited from parents, but there is a genomic predisposition we will come back to later. So from a pathogenesis point of view, the PSC can arise from the large bile duct or from the small intrahepatic bile ducts, and we will see how these two scenarios have different clinical implications. And there is a number of different cell types which are involved into generating these inflammatory diseases. It looks like the immune system is deregulated in this disease, and the abnormal immune response seems to be driven by a polarization towards a Th17 response, which from recent studies seem to be driven by monocyte and macrophages stimulation as well. So a lot of different cells that take part to the mechanism altogether. Why do we need to talk about cancer when we discuss PSC? Because unfortunately, up to half of these patients die because of cancer. And you can see from the schematic representation, PSC patients have an increased risk of different cancer types. Hepatocellular carcinoma has been described, even if the increase in risk is not very high. Gallbladder cancer is higher in this population compared to the normal population. But above all, we have a significant and remarkable increase of cholangiocarcinoma, which is about up to 400 times compared to the normal population. So if we consider, the cohort of patients with PSC, we know that the annual incidence of cholangiocarcinoma in this cohort sits between 0.5 to 1.5%, and the lifetime risk of developing cholangiocarcinoma for a patient with PSC is about 10%, with some reports saying up to 20%. You can also see that these patients are at increased risk for colorectal cancer, and this is related to the fact that patients with PSC frequently develop inflammatory bowel disease. Here are the data for the genomic predisposition that I discussed earlier. You can see that there are selected synchronucleotide polymorphisms which are associated with the risk of developing PSC, with this Hubbard-Sheffrey, which seems one of the most important. But very interestingly, this international consortium group has also tried to identify the genomic-wide and genetic correlation between PSC and IBD. And you can see that they found there is a correlation between the genomic of PSC and ulcerative colitis, which probably suggests why up to 75% of patients with PSC also are diagnosed with ulcerative colitis. And ulcerative colitis is a pre-malignant condition for colorectal cancer, which justifies now the increased risk of this tumor in these patients. So what about specifically cholangiocarcinoma? Because we have said if we take the overall cholangiocarcinoma population, we know that only 10% are associated with PSC. But if we take the cohort of patients with PSC Now, we know that cholangiocarcinoma can be the presenting features in many of these cases. In half of the cases, we know that the diagnosis of cholangiocarcinoma follows that of PSC by few months. However, not all patients with PSC develop cholangiocarcinoma. We have seen this before, about only 10 to 20%. However, these patients are much younger compared to the normal cholangiocarcinoma population, and cholangiocarcinoma is one of the limiting factors for their curative treatment, which consists of liver transplantation for PSC. Now, you remember I told that PSC can arise from small bile duct or from large bile duct. In the case that the PSC is affecting only the small bile duct, these have a much lower risk of developing cholangiocarcinoma, and overall the clinical outcome is much better. While the PSC from the large bile ducts usually is associated with an increased risk of cholangiocarcinoma, and in terms of subtyping, we mainly have a perihilar cholangio up to 75% of cases, with probably 15 up to 20 of distal cholangiocarcinoma, and then the rest is intrahepatic cholangiocarcinoma. So these patients are at risk of developing cholangiocarcinoma. How can we monitor them to identify this tumor at an early stage? Unfortunately, we do not have any data that any instrumental or invasive methodology for surveillance is better than another one. So here I report the guidelines, the UK guidelines, but different countries have produced very similar guidelines. We do not have a recognized recommendation for how to surveil these patients. So management is actually down to the local different institutions according to their interest and their expertise, and some proposing annual imaging with MRI or MRCP, and then a periodical CA 19.9, reserving the more invasive technology just for very highly suspicious cases. Now, these data take, a very important message to discuss, which is the need for a diagnostic biomarker for cholangiocarcinoma. Now, if this is something that is important in all cholangiocarcinoma, it's specifically important in the cohort of patients with PSC. This slide is just to show you that there is a lot of effort towards this area and research in this topic, and it doesn't want to be comprehensive, but just a couple of examples of the effort that have been put into this this question. So on the left, you see the proposition of an early diagnostic biomarker based on a methylation pattern in brushing cytology, where cholangiocarcinoma cases result to be different from the PSC one. On the right, you see the attempt to study the content of extracellular vesicles, which can be isolated from the plasma of patients. So this would be a non-invasive biomarker. Both these biomarkers, as well as all the biomarkers that are currently studied and researched in the area, have not reached the phase of clinical applicability yet. So we still need the prospective validation. Can we reduce the risk of cholangiocarcinoma in these patients? A lot of effort has been gone towards the study of ursodeoxycholic acid, and because of the promising result in PBC. Unfortunately, we can't say the same with PSC, and so this is not recommended because, if anything, it looks like it's increasing the risk of colorectal cancer. So I thought to just spend 2 words about aspirin, and this is becoming quite an hot topic at the moment. So which are the data about aspirin and cholangiocarcinoma risk? There are a few reports out there from different institutions and different countries. I'm showing here the data from the Mayo Clinic, which probably is one of the largest cohorts. And you can see that they have found a significant inverse association between the use of aspirin and the cholangiocarcinoma, which seems to be across all different types. And these are in association with the more recent data you might be aware of, where the use of aspirin has been associated with a reduction of overall liver-related mortality. Again, retrospective data that needs confirmation before we can take them to clinical practice. From a biological point of view, we said these tumors arise from the large bile duct cells, so they tend to produce mucin. They do have an extensive involvement of the peribiliary gland, which are the niche where you can find cells with cancer stem cell marker. how these cells are exposed and responded to the inflammatory stimuli occurring in PSC and to the derangement of immune response is still yet to be determined. From a genetic perspective, we have a lot of data now after this publication, which looked at one of the largest cohort of PSC-only related cholangiocarcinoma, up to more than 180 cases studied. The bottom line is that these reflect the genetic profile of extrahepatic cholangiocarcinoma. So we do find actionable therapeutic targets, but we can think of finding IDH or FGFR. So mainly we have something resembling the extrahepatic bile duct profile. Now, moving to the next syndrome, the Lynch syndrome. Someone of you might have been lucky to meet and know Dr. Lynch, who unfortunately passed away last year. He was the first who identified that if you have a mutation in one of the MMR gene, mismatch repair gene, then you tend to have an accumulation of DNA damages and genetic errors. This is the confirmation of these data. You see that, the orange dots across all cancer, orange dots means mutation in the MMR genes, are associated with an increased MSI. The clinical reflection of this phenomenon is that the patient has an elevated risk of developing cancer, mainly in colonic cancer, but we also know that the tumors can arise from other organs, and they include the stomach, the biliary tract, the urinary tract, the small bowel, the ovaries, and the endometrium. The interesting point is that according to the gene where the mutation occurs, you can have a different risk of developing different extracolonic tumors. If we focus on biliary tract cancer, we see there is mainly a derangement and an impairment of the MLH1 gene, and I have not displayed the data, but this risk also increases progressively with increasing of age. Interestingly, it's very rare that patients with Lynch syndrome, they do have only biliary cancers. They tend to develop colon cancer first, and then, after a period of time, they might have biliary cancers. And according to this study, there is a gap between 6 years between one diagnosis and the other. Overall, if we take a patient with Lynch syndrome, the risk of developing biliary cancer is not very high. It sits between 0.5 and 2%, and the tumor can arise from every single site of the biliary tract system. Now, we've said before that Lynch syndrome means MSI high tumor, but the opposite is not always true, because the MSI can also be related to somatic mutations or to epigenetic phenomena. What is important is that we can also look at the loss of these proteins, because this is what can make the tumor MSI. So I decided to present this data, which is quite recent, just to give you an idea that sometimes the immunohistochemistry of these proteins can be the first step for screening for MSI. Now, if we consider MSI high component of tumors and not the Lynch syndrome, how frequent is this in biliary tract cancer? Well, it's not very frequent. So we know that probably between 0 and 5% of biliary tract cancer are MSI high, a little bit higher maybe in intrahepatic cholangiocarcinoma. I would consider them pulmonary carcinoma an independent entity, as these are usually related to MSH6 mutation. And as you know, they usually have an intestinal phenotype that might resemble more a colonic cancer. The importance of identifying this feature is that MSI high cholangiocarcinoma have usually a better prognosis, and they have a particularly different infiltrate in terms of immune response and immune cells, and this we know is related to a better response to immunotherapy. So clinically and therapeutically, we have now an impact on these cases. So to conclude, the majority of cholangiocarcinoma, remember, are still sporadic. If we take a cholangiocarcinoma population, about 10% are related to PSC, and about 5 or 10% of these are MSI high. Much less are related to Lynch syndrome. Unfortunately, the surveillance of patients with primary sclerosis cholangitis or Lynch syndrome has not been defined yet, so we don't have uniform guidelines. And once the tumor has developed, it we don't have a different set of guidelines in terms of treatment. There are different implications, and these include immunotherapy, probably in Lynch syndrome-related cholangiocarcinoma, and then the issues of having, immunosuppressive treatment after liver transplantation for those who have a tumor after a liver transplantation for PSC. So I'd like to thank everyone who has helped, especially for this presentation, Giusy Prete, who has helped with the presentation of the slides. Thank you.
I'd like to thank the Cholangiocarcinoma Foundation and the organizers of the meeting to be able to share information today with you regarding perihilar cholangiocarcinoma, which I will abbreviate as CCA for the remainder of the talk and in the slides. I realize these are unprecedented times across the world. I appreciate the efforts of everyone to make this a virtual conference is greatly appreciated. It's greatly appreciated by all of our patients who we are here to serve. The learning objectives for this conference are straightforward. I want to define the anatomic subtypes of cholangiocarcinoma, particularly the subtype perihilar cholangiocarcinoma, or PCCA. I want to talk a little bit about the diagnosis of this cancer. I want to provide insight into how the cell of origin for perihilar cholangiocarcinoma is likely different from other subtypes of cholangiocarcinoma. And I want to highlight the fact that we need to be able to study this form of cholangiocarcinoma separately from the other subtypes. This is anatomic classification of cholangiocarcinoma. There's intrahepatic cholangiocarcinoma, or iCCA, which is characterized by mass-forming lesions within the liver. Perihilar cholangiocarcinoma occurs at the branch points of the large bile ducts draining the liver, and this is called the hilum of the liver, and hence the term perihilar cholangiocarcinoma. Cholangiocarcinoma can also involve the bile duct just before it enters into the intestine, and this is referred to as distal cholangiocarcinoma. This would be an example of a intrahepatic cholangiocarcinoma. Note the mass lesion present in the left side of the liver here with peripheral bile duct dilatation as an example. This would be an example of a distal cholangiocarcinoma where the bile duct is obstructed right before it enters into the intestine and causing dilatation of the bile duct upstream or proximal to that stricture. This is an example of perihilar cholangiocarcinoma, and I want to highlight several features of this disease. First, it often presents with jaundice, and in the upper left-hand panel, or panel A, you see the bile duct dilatation here on the left side of the liver. Panel B is an example of this, a picture using MRI, whereas panel A was a CT scan. Panel C is a cholangiogram of this lesion, and note that we don't see the left side of the liver because it's completely obstructed at that level. And then panel D in your right lower hand corner is a MRI or MR cholangiogram period. Note that here we see a very tight stricture of both the right duct and the left hepatic duct with upstream or proximal dilatation of the bile ducts bilaterally. That one should not appreciate on the cholangiogram and occurs in this hilum region, and this would be very typical of a perihilar cholangiocarcinoma. The reason we differentiate perihilar cholangiocarcinoma from intrahepatic cholangiocarcinoma is that the clinical presentation, painless jaundice, the genetics of the disease and the treatment are quite different from intrahepatic or distal cholangiocarcinoma. This slide highlights the genetic alterations in intrahepatic cholangiocarcinoma, and we are all aware of the focus on the IDH and FGFR2 mutations as treatment targets for this disease. In contrast, these mutations are rare in perihilar cholangiocarcinoma, and we have more mutations associated with chromatin remodeling and the ERB2 family of receptors. Hence, this is a different type of cancer than intrahepatic cholangiocarcinoma genetically. The reason this has often been misclassified as intrahepatic cholangiocarcinoma is illustrated on this MRI. Note that the red arrow points to a lesion of thickening around the bile duct, that this would be a perihilar cholangiocarcinoma. Although this may look like it's actually inside the liver because the right and left hepatic ducts actually are inside the liver. And this has led to much confusion in public databases as to whether a cancer is intrahepatic or not. I've pulled up another slide of this cancer on the MRI images just to highlight the visibility of this cancer and to illustrate that despite the fact that it's a perihilar cholangiocarcinoma, it looks like it's inside the liver. In contrast, you can see here on the MR cholangiogram that this is actually a very tight left hepatic duct stricture. Indeed, Dr. Shahid Khan, who's an expert in the epidemiology of perihilar cholangiocarcinoma, who's in the United Kingdom, has recently looked at the classification of perihilar cholangiocarcinomas in 3 hospitals. They went back to the charts and reassessed the diagnosis of the subtype of cholangiocarcinoma retrospectively. They noted that perihilar cholangiocarcinoma was incorrectly diagnosed as intrahepatic cholangiocarcinoma 92% of the time. Hence, this is a gross misclassification of perihilar cholangiocarcinoma as intrahepatic cholangiocarcinoma in very sophisticated hospitals in the Western world. Hopefully this will be rectified over time. There is an international classification of diseases termed ICD. In 2022, there will be implemented the ICD-11. This will, for the first time, include topographical codes for intrahepatic, perihilar, and distal cholangiocarcinoma. There's also an international classification for disease of oncology, ICD-O, and the ICD-O-3 will mirror the ICD-11, providing 3 distinct codes for the subtypes of cholangiocarcinoma. This will be a significant advance and will allow us to epidemiologically better classify the subtypes of cholangiocarcinoma so they can be examined differently. This would be a distribution of cholangiocarcinoma subtypes seen at the Mayo Clinic over several years. This includes over 1,000 patients, period, and you can see that 43% of cholangiocarcinomas are actually of the perihilar subtype. The major risk factor that we understand for perihilar cholangiocarcinoma is primary sclerosing cholangitis and inflammatory sclerosing disease of the bile ducts. But primary sclerosing cholangitis only accounts for about 8% of patients with perihilar cholangiocarcinoma, and so 92% do not have identifiable risk factors, unfortunately. As I said at the beginning of the talk, perihilar cholangiocarcinoma often presents with jaundice. This is because the cancers encase or constrict or narrow the bile ducts, leading to impaired bile flow and the retention of bile constituents within the blood plasma and circulation. This requires stenting, and this would be an example of a stent transversing a stricture in the perihilar region to resolve jaundice. The diagnosis of perihilar cholangiocarcinoma is very difficult because it presents as a narrowing of the bile duct, usually without a mass lesion identified on MRI or CT scans. There are benign causes of bile duct obstruction, and hence the differentiation can be complex. There are a number of evolving techniques to better diagnose perihilar cholangiocarcinoma, and they're illustrated on this slide. They include circulating biomarkers, assessment of biomarkers in bile, and then brushings of the stricture that can be obtained endoscopically at the time stents are placed or an endoscopic cholangiogram is performed. One of the problems is that routine cytology, which simply mimics a pap smear of the bile ducts, is very insensitive for the diagnosis of cholangiocarcinoma. This slide shows what normal cytology would look like compared to atypical cells, then suspicious cells, and frankly positive cells. Unfortunately, the pathologist or cytopathologist usually gets a specimen with very few cells on it, making it a very difficult call as to whether this is normal, atypical, suspicious, or positive for cholangiocarcinoma. We have used advanced cytologic techniques to aid in the diagnosis of cholangiocarcinoma, and our approach is to use fluorescent in situ hybridization, abbreviated, to identify regions of chromosomes. You should have two chromosomes, one from your mother and one from your father. If there's a duplication of the chromosomes, that's consistent with chromosomal instability, and it's one of the hallmarks of cancer. Hence, if you have more than two signals per color in this assay, that would represent chromosomal duplication, and you have more than one chromosome duplicated, that would be indicative of aneuploidy or marked chromosomal instability. It'd be quite consistent with malignancy. Indeed, we've looked at conventional cytology and FISH in our primary sclerosing cholangitis population period. This is a population for which the diagnosis of cancer is extremely difficult because the disease itself causes narrowing of the bile ducts. And you can see that conventional cytology only identifies 18 to 20 patients out of 100 with the cancer, although when it's positive, it's quite specific. We can double or triple that number with FISH, which has proven quite valuable in the diagnosis of this cancer. This slide illustrates an algorithm for which we use to diagnose this cancer. I will highlight that we often use this in conjunction with the serum CA19-9, and that if a patient has a FISH polysomy and a high CA19-9 or FISH polysomy with suspicious cytology, over time they likely have a cholangiocarcinoma, and it helps us make a diagnosis earlier rather than later. Finally, I want to speak a little bit about the cellular origin of cholangiocarcinoma. Cholangiocarcinoma may arise not from the bile duct itself, but from small glands surrounding the bile duct, termed peribiliary glands, period. And hence, its cell of origin would be different of that from intrahepatic or distal cholangiocarcinoma. This illustration highlights that we have these glands as a sort of a side branch of the major bile duct, that during cell injury, these glands are a source of new cells to help line the bile duct, but with increasing proliferation of these cells, they may acquire mutations, which then results in cancer formation. The reason I think this is highly important is because most of the treatment studies for cholangiocarcinoma comprise mainly patients with intrahepatic cholangiocarcinoma and gallbladder cancer. And if one looks carefully at the treatment results for perihilar cholangiocarcinoma, one remains unconvinced that we have effective therapy for perihilar cholangiocarcinoma. So in the GEM-CIS study, which really created the standard of care for gallbladder and intrahepatic cholangiocarcinoma, we'll note that the perihilar cholangiocarcinoma group I have here is boxed in red. The confidence intervals cross 1, and hence suggesting there's a lack of efficacy. And even if one looks at the BILCAP study, which was an adjuvant study for the treatment of patients undergoing resection for cholangiocarcinoma, one will again note that the perihilar cholangiocarcinoma group, which comprised roughly 30% of the patients in this study, again, the confidence intervals crossed 1, again suggesting there was a lack of efficacy in this group. So in summary, I would like to highlight today that the perihilar cholangiocarcinoma subtype of cholangiocarcinoma is often erroneously classified in existing databases as intrahepatic cholangiocarcinoma. Newer ICD codes are meant to address this problem, but the previous data and previous coding has to be viewed with suspicion, and is likely erroneous in terms of the type of cholangiocarcinoma that has been coded. That advanced cytologic techniques are helpful in the diagnosis of this cancer. That a standard of care with systematic treatment for perihilar cholangiocarcinoma has yet to be robustly established. And we need to have more concerted efforts on this subtype of cholangiocarcinoma with appropriate stratification and treatment trials. And that this cancer likely can originate from peribiliary glands and therefore has a different cell of origin than other forms of cholangiocarcinoma, explaining why we need to tailor the treatment for this subtype. Thank you, and I'd be happy to address any questions in the question and answer period. Thank you.
Good afternoon. I would like to thank the organizers for putting together this great panel addressing one of the major issues that we are currently facing in the management and study of cholangiocarcinoma. I will present all the panelists, and we will have 15 minutes for discussion and Q&A presentation. So the first talk was presented by Kristen from the Incyte Corporation. Hello, Kristen.
Hello.
Welcome to the panel. Then we had Louis Roberts from Mayo Clinic, who is a key opinion leader in the genetic studies of cholangiocarcinoma. Hello, Louis.
Good afternoon.
Eileen O'Reilly from the Memorial Sloan Kettering Center in New York, who doesn't need any presentation. She's a medical oncologist that has done great study on the germinal mutations in pancreatic and biliary cancers. Hello, Eileen.
Hi, Anna.
And Chiara Braconi from Glasgow, who's done amazing basic research on cholangiocarcinoma. And finally, Professor Gores, who doesn't need any introduction. He's been a key opinion leader in the research field of cholangiocarcinoma from Mayo Clinic for a long, long time. So I would like to start with some of the questions that the attendants have asked. One of the most repeated questions that I've seen is the necessity for genetic testing in patients and relatives. So I would like maybe Louis to comment on that, since you have presented all the GWAS data, and considering what Kristen showed us, that most of the patients have a 2-year delay in diagnosis. Do you think is or it will be in the near future a useful tool to have genetic testing done?
Thanks. That's a good question, and I think we have to be careful when we describe exactly what we mean by genetic testing. So, for example, we started the meeting this morning with a presentation on biomarkers and the fact that biomarkers matter. And I think much of the effort there is on testing the tumors themselves to identify whether there are specific genetic mutations or fusions or other changes within the tumor that patients have that might help us in terms of prognosis or predicting what the best treatment is for patients. And that's clearly valuable today. And I think one of the big messages that we have for patients and their families, members, and advocates is that if you have a tumor, certainly that tumor should be tested genetically or genomically, because we are able to use that information to determine the best treatments. I think the other question is, can we determine through a person's genes whether they are at high risk for developing cholangiocarcinoma? And that's where we are just really at the beginnings of really these studies. So these studies, such as the one that I described, this is actually the first one that you could even call large enough that we could maybe pick out something that's a major risk factor. But the reality is that it's actually still too small. And what we learned was that we need more samples to really be able to tell effectively whether we can predict from a person's inherited blood DNA whether they're at high risk. So I think those two are quite different.
Yeah, absolutely. So, Eileen, picking up from here, some people ask if the mutations that you see in the tumor diagnosis in the histology are if you need to repeat testing and after treatment. Is it useful to have the patient rebiopsed in order to see if the mutations have changed?
So thanks, Anna, and thanks for the question. I think this is an important one and a very topical one. And there's two aspects to this. One is how it applies to clinical care, and the second, where it interfaces with research. So with regard to testing up front, and to echo what Dr. Roberts mentioned, we recommend ubiquitous testing for all patients in terms of tumor assessment. I think more discussion about whether we should routinely test in terms of germline, I would advocate yes. But moving to the topic of repeated tumor-based biopsies, because the germline, for the most part, stays relatively stable. It's, I would say, in terms of utility, it's helping defining mechanisms of resistance and strategies that might overcome mechanisms of resistance. And so an example might be an individual who has an FGFR2 fusion, and Dr. Goyal has provided some nice work along with many others in the field showing that mutations can build as the tumor is exposed to the drug that targets that mutation, and that there may be ways of trying to overcome those resistant pathways. So we're seeing this more in biliary cancers and in pancreas cancers, but I would say we still have a huge amount to learn here.
And Chiara, what happens with those patients that have Lynch syndrome? So in those cases, what do you recommend regarding, or what are the guidelines, the current guidelines for relatives and children from patients that have Lynch syndrome?
Okay. Well, having a Lynch syndrome means that the mutation is present in all different cells of the body because it's a germline mutation, and so this is why it's associated with increased risk of cancer. So usually, these patients have a consultation with the genetician, and their children might decide not to For those individuals who come positive and they are with mutation, then there is still a lot of debate how and how frequently and which technologies we can use to really monitor the cancer development. Usually we tend to focus on the monitoring of colorectal cancer because that is something that is more easily done in some way through endoscopies. It's true that monitoring the development of a cholangiocarcinoma is much more difficult because it's still the diagnostic challenges we face in the radiological diagnosis of cholangiocarcinoma in general. And then for patients who have Lynch syndrome, when they do develop cholangiocarcinoma, more frequently they do have MLH1 mutations, and they tend to, as we know, as we've seen the data. Seems like, can you hear me?
So.
Okay. For those patients who then have a mutation in MLH1 because of the Lynch syndrome, then they tend to have the possibility of exploring, other treatments like immunotherapy, for example. Did you hear me? Or do you,
can a patient? It's a little better. There is a question for both Chiara and Eileen. Can a patient have more than one mutation? And if that's the case, how do you manage treatment?
So in terms of the tumor for a minute, some mutations tend to be exclusive of others. So for example, IDH mutations, which are potentially targetable, and FGF alterations of fusions targetable. We don't tend to see those together. It's certainly a luxury when there are a number of targets. In the germline, it's unusual to have two what we call pathogenic or significant alterations, to see those together in the germline. But occasionally, for example, I've seen a patient who had both BRCA1 and BRCA2, presumably inherited from different sides of the family. But they're very, very rare occurrences.
Thank you. And then there've been a couple of questions for Gregory regarding the misclassification or misdiagnosing of intrahepatic cholangiocarcinoma. So can extrahepatic or perihilar cholangiocarcinoma be misdiagnosed? And if that's the case, how do you manage the patient? What can the consequences be?
Yeah, thank you. Yes, the short answer, it can be diagnosed. So when Dr. Khan did this study, which is yet to be published in the UK, he had examples that went both ways. So he had intrahepatic cholangiocarcinomas misdiagnosed as perihilar, and then perihilar misdiagnosed as intrahepatic, which is much more common. But even they had some surprising findings that even true distal cholangiocarcinomas could be misclassified based on anatomy. I think the consequences of the misdiagnosis are both from an epidemiologic perspective and then from a preventive and then treatment strategy. So until we get the coding right, we'll never know which subtype of cholangiocarcinoma is increasing or decreasing, and which ones we should focus more on for prevention. That's virtually impossible right now with the current data that we have. And then, because I think the etiopathogenesis will be different, we will have different strategies for prevention. And then I think the treatment will also be different. We've heard a lot about genetics and matching genetic aberrations to treatment for intrahepatic cholangiocarcinoma, but we know very little about the genetic aberrations of perihilar cholangiocarcinoma. And until we actually make the distinction and define that, and then we can do the genetics properly, we're still going to have a lot of confusion.
Yeah, thank you very much. So there's a final question. Suppose that a BRCA mutation does not itself cause cancer, but it facilitates its development. In any case, is there any other mutation that is required besides BRCA? Maybe, yes. I don't know, Eileen, you can address the question.
Yeah, maybe to make sure I'm understanding correctly here. So a person can have a BRCA mutation, and they can have a tumor that might be associated with a BRCA mutation, but in that person, they're not connected. And this is actually a very important thing from the treatment targeting perspective. And so we always look to see if it's present both in the tumor and the blood. And the way that's assessed is loss of heterozygosity or loss of the second allele or the second hit. And that increases, when that second hit is present, it increases the opportunity for therapeutic targeting. So, for example, with platinum drugs in the context of BRCA mutation or for PARP inhibitors. And in malignancies such as pancreas cancer, where a lot of work has been done, we know that the loss of the mutation in the tumor is present about 80% of the time, 75, 80% of the time. In biliary cancer, because we have much less information on germline testing and results, because it's not standard of care, it remains to be seen whether it's as high an event or not. And this is why when we do genetic testing, that we want the information from both, because it optimally calls within the tumor, and it certainly optimally calls what's in the germline. And this is, it's really ideally an integrated process.
Okay, thank you very much. There's a question from Jesus Banales to Gores. Is there evidence of congenital biliary malformation associated to perihilar cholangiocarcinoma development?
Not well defined in the literature. Thank you for your question. There are these anomalous pancreatic duct insertions, which are higher up than at the level of the ampulla, which have been associated with biliary tract malignancy, but those are more likely distal cholangiocarcinoma. So there's been no congenital abnormality that's been linked to the vast majority of perihilar cholangiocarcinomas. In patients who may have fibrocystic malformations of the biliary system, which are genetic, they can have perihilar cholangiocarcinoma.
Well, thank you very much to all of you. It's been a great session. I've learned a lot, and it's always great to really listen from people that are actually top in their field. I thank again the organizers for putting this session together. It's been very, very interesting, and I hope you really enjoy the rest of the meeting. Bye.
Bye-bye.
Bye, everybody. Thank you.
Bye.